Hello, my name is David Swope. I'm a movement disorder neurologist at Mount Sinai Hospital in New York, and I'm joined by Dr. Michael Pourfar, who's also a movement disorder specialist at NYU here in New York. And we're here today to discuss Parkinson's disease. We're going to talk about the diagnosis, the treatment, some of the complications of Parkinson's disease. So this is a very complex disease. It tends to be a disease of older people. Affects roughly 60 to 100,000 people in the U.S. Each year, and it's a disease that usually gets diagnosed around the age of 55 to 60, but the prevalence does become greater as people age. We do see it in younger patients as well, and we'll talk about that special group as we go on. What we're going to do is try to discuss some of the basic principles of diagnosing, treating Parkinson's, and as well as the complications that arise, and things that we can do to maybe treat the complications and potentially even lower the risk of developing complications. So Dr. Pourfar and I both treat patients with Parkinson's disease every day. We've been involved in clinical trials with Parkinson's disease, involved in both medical and surgical management of Parkinson's disease. So I think we'll get started.
Sounds good.
So, Michael, let's talk first about the diagnosis of Parkinson's disease. Tell me, how do you make the diagnosis of Parkinson's disease?
Well, one of the things that I think is so interesting and challenging about Parkinson's is how variable Parkinson's disease is. And I think one of the things that we try to get across, I'm sure as you do to the residents and fellows, is sometimes you've seen one Parkinson patient, you've seen one Parkinson patient. So if you're waiting for the classic tremor, you're going to miss a lot of other things that are in fact Parkinson's. So we talk about the four major motor symptoms of Parkinson's, which are resting tremor, rigidity, slowness or bradykinesia, and postural instability. And usually we look for two of those four things on the exam, but as you can weigh in on too, there's often a lot more than that that gives us clues that that's what we're dealing with. So what would you say, David, are some of the maybe the less well advertised telltale signs of Parkinson's?
Well, we see a lot of things related to slow movement, but there's things we call the non-motor symptoms that often arise even much earlier than the motor symptoms. Things that can be maybe more in retrospect a hint that this could be Parkinson's disease. Things like constipation and sleep disorders like REM behavior disorder. Depression, anxiety, also very common in Parkinson's. And so these are things that we ask about. We like to hear from the family if any of these conditions have been occurring over the years. And this can tell us that there may be some Parkinsonian syndrome developing. When we hear some features like balance difficulty or cognitive problems, these, can occur in Parkinson's disease, but they tend to be something that occurs later in the disease. So it's a bit of a red flag when we get those early in the disease. What do you think about differential diagnosis of Parkinson's? When you see somebody with stiffness and slowness, maybe not much of a tremor, how comfortable are you saying that that's Parkinson's?
Yeah, I think it's important to point out that about a third of Parkinson's does not have a tremor. This is what we call the akinetic rigid variant. And so it's important a lot of times when as movement disorder specialist, I get sent somebody that the general neurologist is not sure this is Parkinson's or not. A lot of times it's because there's no tremor, or there's a tremor maybe in the foot as opposed to in the hand. Or there's something that looks sort of Parkinsonian, but there are a lot of other problems. People get older, they're not walking right. How do you differentiate between a Parkinson gait problem and an orthopedic gait problem? And typically by the time Parkinson's presents clinically, there are, as you said, a bunch of non-motor symptoms and also some more subtle signs and things that you can look at, like facial expression, arm swing, other things that go beyond whatever the patient may just be complaining of right there. You can tell we're recording in New York here as the sirens go by, but hopefully that's not too distracting for our listeners.
I think we should mention Parkinson's diagnosis is primarily a clinical diagnosis still, although now we have some technology that can be useful if used in the right settings. How often do you get DAT scan, dopamine transporter scan, on your patients?
Okay, so to maybe talk a little bit to what everybody already knows, Parkinson's is largely, but not exclusively, an issue of a dopamine deficiency state. And so looking at dopamine levels with a DAT scan, although there are other ways to do it, that's the one that's now approved in the US, sometimes gives you a little bit of extra information when you're not sure based on the clinical presentation. Most of the time I don't really need it because it is, as you said, a clinical diagnosis. But there are times when either there are a lot of confounding aspects, somebody who had a stroke and has a replaced hip and you can't quite put it all together. Somebody is maybe on a medication that can make things look like Parkinson's and you're not sure, is it the drug, is it, is it Parkinson's? Or you've treated them under the presumption that it was Parkinson's and they don't seem to be getting better and you want to take a step back. How about you? When do you find that you use it?
Yeah, I find it useful in a couple situations. One is I like it in young patients because I'd like to have something more objective to tell the patient that convinces them they have Parkinson's. Because if you're talking to a 30-year-old person and saying they have Parkinson's, it's not an easy thing for them to take. And if they have some tests to back it up, then they tend to maybe believe you and trust you more as a physician. Also, I use it if I think somebody has a psychiatric condition causing their Parkinsonism, like a psychogenic form or a drug-induced Parkinsonism. They should have normal scans. The one thing I think it's important also to point out is that the DAT scan does not differentiate between Parkinson's disease and some of the other Parkinson's syndromes. So somebody could still have something like multiple system atrophy or progressive supranuclear palsy, have an abnormal DAT scan and look Parkinsonian, and you may not be able to get the exact diagnosis from that test or from your exam. So
right.
Time will tell.
Yeah, I think it's important to note that it is not, it does not specifically diagnose Parkinson's if it's abnormal. And on the flip side, just like with any tool that we use, it is not 100% foolproof in the reverse either. I have seen patients who, in my feeling, have clinically diagnosable Parkinson's who have equivocal DAT scan results. So although it is very helpful in some cases, at the end of the day, I still tell the patient that this is my working diagnosis based on, these symptoms.
Mm-hmm. Mm-hmm. Yeah, and there's not, for the vast majority of people, there's not any specific biomarker that we can use to help us diagnose. There are some genetic forms of Parkinson's where there are gene mutations associated with the higher risk and family history of Parkinson's. I don't usually get those tests very often. Certainly not in the run-of-the-mill 55 or 60-year-old person who comes in with a tremor and Parkinsonism. It's usually people who have at risk, we'll say, with family history and maybe some early onset where that can be useful. And again, it's useful in telling you the cause, but it doesn't really change your treatment. And a lot of times I find that patients, if it's not going to change what I do for them, they may not even want to get any kind of genetic testing. But it may be important for their family to know.
So what do you tell a patient when they say, there's all these ways now I can get myself tested genetically, and what do you think about it? What is your general approach in terms of the genetics, as we're learning more and more about it all the time?
Well, yeah, one thing I always have to consider is the cost. A lot of times the patients will have to pay for it, and if they can afford it, that can be useful. And it's really more useful, I think, for their family to know if their children are at risk or grandchildren at risk. But even some of the risk, we're not even certain how much risk there is. So it's still, it's good information to have. I think a lot of it is being tested for research purposes. So when we're better at understanding genetics, it'll be more useful. Maybe there will be certain genetic forms that respond better to one treatment than another, and that may be something down the road. For now, I tell people it could be something that might be interesting and helpful in some ways, but all in all, it's not going to change really how we manage that person.
Right. I would say it's safe to say, certainly at this point, it is not a biomarker insofar as you wouldn't send off a genetic test result to confirm your suspicion of Parkinson's if, if somebody had soft findings, for example. So it really is more in the research arena at this point. It doesn't really seem to greatly impact how we treat the patient.
I agree. And a lot of times patients, when they understand that, they're not really that excited about being tested, especially if they have to pay several $1,000s for a test that's not going to really alter their treatment. So when I talk to people, telling them that they have Parkinson's, I find that they come to our office for a reason. There's something that's bothering them, something that's not right, and they often know that there's something wrong, and many of them have been told maybe you've got Parkinson's disease. And I think being upfront and honest with the patient is good, and I tend to stress the positives about good treatment and things that we can do that maybe will make them better off 10 years from now than they would be otherwise. And then I also talk to them about new treatments that will be becoming available in the near future that can also potentially alter their course of illness.
Yeah, I mean, most of the people that see us often have been sent to us by an internist or a neurologist who says, look, I think this is what we're dealing with. And of course, by the time they've even gone to that doctor, they've often been having these symptoms for quite a while. So I try to put it in the context of, look, now we understand why, not just 3 months ago, but now that we get into your history, why a year ago, why 2 years ago, you were having trouble with this and that. And now we can do something about it. And thankfully, we have a lot of things we can do about it. And I always have the caveat, we're not going to put on rose-colored glasses. It's going to have some challenges. But, most people live with their Parkinson's rather than die from it.
Right.
And I think everybody's mind goes to the worst-case scenario, I'm going to be in a wheelchair. And I tell them that's just not my experience, that most patients do not end up in a wheelchair, for many, many, many years, if ever, and that we have a lot that we can do for patients. So it requires follow-up and monitoring, but I think part of that conversation is also about empowering them to get involved in their care too, about exercise, about diet, and about being vigilant with their doctor as well as with themselves about some of the things that they may experience, as you mentioned, some of the non-motor symptoms that they may not think to bring up, but that are big quality of life issues that we can treat.
Well, I also find that a lot of times patients, once they get the diagnosis of Parkinson's disease, then everything that happens to them, they attribute to Parkinson's disease.
Right.
So part of our job is to tell people, well, this is from Parkinson's and this is not. If you're having trouble breathing, you should maybe see your internist or your cardiologist. And don't blame it on the Parkinson's because you don't want to miss other things. And I think it's also good. I at least give my patients the information and the option of support groups. Some people really like to hear how their other people with Parkinson's are dealing with this problem or that problem, and what can they do. They can go and sometimes learn from lectures and things. And then you have other patients who just don't want to be around other people with Parkinson's. They don't want anything to do with it. But I let the patient kind of make that decision themselves.
Yeah.
But at least they should know that these things exist.
Well, I think, I agree. And I do think that one of the nice things about modern media, of course, it can cut both ways. People going online, finding out things that are not necessarily true or validated. But on the other hand, they can find a community that is appropriate for them. Because one of the difficulties with Parkinson's is, as you said in the beginning, it can affect a 20-year-old mother, and it can affect a 78-year-old retired gentlemen, and they're not going to be on the same page in terms of a support group. So
Right.
there are things through Facebook and other opportunities now to find people who are experiencing some similar issues. And I like to direct them to some websites that I think are reputable, sites like the Michael J. Fox or the Parkinson's Disease Foundation websites that can sort of introduce them to various levels of either questions they might have or community outreach things that they can participate in.
Yeah, I'll also throw out the Davis Finney Foundation. I'm a fan of that one too. So
yeah.
I think that's a good one, and let people know what's out there, and then they can go from there. So let's think about if we have a patient whom we've diagnosed with Parkinson's disease, and now their symptoms are fairly mild. Let's talk about the treatment options we have for these people and how we go about deciding what to do in a given case. I always try to focus in the beginning on general health. I always tell people, if you've got a disease that affects your movement and you're in good physical condition, you'll probably tolerate it better than if you're, lying on the couch and drinking beer every night. So things like that I think are useful, as well as the importance of exercise. And I try to make sure that they realize it's strenuous exercise, not just pushing the vacuum cleaner around the house. So I want them to get out there and work, and I think that's very good for the brain in Parkinson's. It's good for the brain in general, and it's good for movement and balance. And I think there's lots of evidence to support that it does have a good effect over time on the symptoms of Parkinson's as well.
Well, I think so too. And what I try to do when I'm talking about exercise is bring to fore that there is a lot of data, not just human data. There's animal studies looking at Parkinson-like, rodents and other things, and exercise versus lack of exercise, and the benefit that it does and has to be maintained. But that we have to be realistic, and you've got to find an exercise that suits you. A lot. There always seems like there's some new study. You should try boxing. You should try Tai Chi. You should try this. And I always say, well, you should try what you're going to actually do. So
right.
You have to be able to connect with the patient. What are they really realistically going to do in terms of exercise and diet, and in terms of symptoms. I always just try to take a step back because there's so many symptoms, as you said, that can happen in Parkinson's. What are the ones that are actually bothering the patient, affecting quality of life? Because I've had plenty of patients that really have a significant tremor, and it doesn't bother them.
Right.
And so I don't treat them, and I can have somebody who has anxiety, which you might not think of as necessarily related, possibly related to Parkinson's, that's affecting their life in a more meaningful way, affecting their sleep. And so, trying to figure out what's going to make their quality of life better out of the laundry list of all the things that a Parkinson's patient can have is sort of an ongoing iterative process with the patient.
Yeah, I have my one rule of thumb is just do one thing at a time.
Yeah.
And so if you're going to treat the anxiety, you treat that. If you're going to treat the tremor, you treat that. Not make the treatment complicated to the point where they come back with a side effect and you don't know what caused it.
Right.
So, and this is a chronic disease we're treating for the rest of their life, and so there's nothing that happens suddenly or quickly, so we have time to make changes, and you have to prioritize what is the most important thing right now, and then let's focus on that. And certainly patients get more complicated over the course of their disease, and another thing I learned when I was a fellow is as the patient gets more complicated, make the treatment more simple. And that's always stuck with me, and it's I think there's some pretty good pearls that we can follow that will make the life of our patients much better. I think when it comes to starting treatment, there's always a question, when is the best time to begin treatment, or when do we need to begin treatment? There are some drugs that might have some effect on disease progression, although nothing's been proven. But I think if you look at studies like the L-DOPA study and things like that, people who do get treated earlier do better. They do have better quality of life, and they do, I think their movement is better, their mood is better, and there's not a good reason to delay treatment, I think, once the diagnosis is made, unless they're just so mild and they don't want to take anything. Okay, so let's talk about when we get a new diagnosis of Parkinson's disease, what do we do in terms of treatment? There's lots of options these days, and what's your general principle?
Well, the general principle comes back around to what we were talking about before, which is that Parkinson patients can look so much different from one to the other that I don't have a one-size-fits-all approach. And there are AAN guidelines, there are a lot of published guidelines that will give you algorithms, which I think are useful to consult with and to have an understanding of. But really my approach to patient management is fairly specific, although there are some broad outlines. So the first question I have is, do we need to treat this patient right now? Do we have symptoms that are affecting their quality of life? And if we do, to help deal with the fear that a lot of patients have about starting on these medicines. A lot of people have read online or heard that there's all these possible side effects, which certainly our medicines can have, but to kind of bring them on board slowly and work slowly, because we are dealing with something that is usually chronic and slowly progressive, and figure out if we are treating, what symptom we're going to go after first, what medication seems most appropriate, perhaps gentlest to begin with, and then a slow titration to get to the lowest, most effective dose. It's common sense, but it's also predicated on a broader understanding of all the things you need to think about now and that you may need to think about with this patient in 5 or 10 years. How about you?
Right. Yeah, I like to think about, number one, what is bothering this person the most right now? And I'll ask them that very question. If we could fix one thing today, what would it be? That way I can focus on one area, because otherwise they often have a long list of things that may be bothersome, but it's good to focus on one thing. Also, especially early in the disease, I think it's important to remember that things we do now may have an impact 5 to 10 years later in terms of their response to treatment and so on. So you have to tailor the treatment for the individual patient. You know, it is different to treat a 75-year-old patient who's retired and spends most of his time at home compared to a 40-year-old who's still working and is going to be potentially more prone to getting complications from therapy. And so I think it's good to know what the options are, what the good effects, the bad effects, the complications of these drugs are, and then tailoring your treatment for the individual. And I always say you see a lot of Parkinson's patients, and no two of them are exactly alike. So everybody gets
that's true. But here, I'll give you a fairly typical one, if there is a typical one, of a, let's say, relatively young man, 50 years old, who comes to you for confirmation of the diagnosis. He's had symptoms for, let's say, a couple of years, maybe a little longer in retrospect, and is bothered by his symptoms, whatever, let's say some stiffness, some slowness affecting him at work, getting dressed, but is very ambivalent about taking medicines. How do you go about broaching that and getting that person to decide what to do next?
Yeah, I think if the symptoms are bothersome, the first thing I want to decide is time to treat, and then it's a matter of what to give that person. We have drugs now that can be given just once a day, which makes it much easier for patients. So one-day oral medication, or even there's a form of dopamine agonist called Nupro that's in a patch, skin patch, that's changed every day. We have things like Azilec, we have other dopamine agonists, Pharmacological, that are once-a-day drugs that really make it much easier to get good compliance, and you can get good results from the simple treatment. I think patients, as time goes on, they're concerned about the number of pills they're taking, how many times each day they take their pills, and anytime you increase something, to them it's a sign that maybe their disease is getting worse. So if we can keep things simple, keep them on once-a-day dosing as long as possible, and keep them moving and doing what they want, then they tend to be happier.
Yeah. And one of the things that I think of as a fallacy, and you can weigh in on, that I try to redirect, or a certain kind of thinking, is that, well, the longer I wait to start a medicine, the better, because it, quote, stops working after 5 years, or whatever they've heard. And they're usually referring, in that case, to levodopa. So one of the things that I try to explain is, you know, it is true we don't want to over-treat you or reach perfection, but there is a downside to simply waiting if you're having problems. And there is a risk to not treating somebody whose balance is not as good. And then if you just wait, when you do finally start treatment, you probably will need a higher dose. And a lot of things that can happen, like fluctuations, dyskinesias, are a product of, at least in part, the dose that we're using. So
dose
that,
plus the disease progression.
Exactly. So if you just wait, I tell them, you know, at some point you're doing yourself a disservice, because you're suffering now, and you're not necessarily even buying yourself any better quality of life by having waited 5 years plus. So I think, you know, we always worry about, well, we don't want to give this person dyskinesias, we don't want to give them, you know, fluctuations, but we don't want to avoid that potential at the cost of undertreating somebody for years.
Right. Well, levodopa is a precursor of dopamine, and this is primarily, at least in the movement part of Parkinson's, it's related to loss of dopamine in the brain from these cells dying off. So replacing dopamine is kind of the gold standard for treatment, even today. But you have to know when is the right time to give levodopa to a given patient. You know, if you have somebody who is younger and maybe very mild symptoms, I think, yes, delay it for several years at least. If you, again, you have a 75-year-old person maybe is having more gait disorder, you may put that person on levodopa right off the bat as a first-line treatment. And so I think it's knowing who's at more risk, who's going to benefit from this drug at what time, and then knowing what your other options are too, because nothing works better than levodopa for treating the motor symptoms of Parkinson's, even to this day.
Yeah, and I do think that you know, it's very in vogue. It's still in a lot of algorithms that you really hold that until after you've tried drug X, Y, Z. And there are times, I think, when you're dealing with a long time horizon that you may want to wait on the levodopa. But I think an argument can certainly be made to start it earlier. There is, you know, more and more data. Certainly, there's been some studies looking at 14 years out. It didn't really make that big of a difference if you started on a dopamine agonist or levodopa in terms of how you were doing in 10, 14 years, at least as regards dyskinesias, fluctuations. So all of these medicines have a place, and sometimes I'll start somebody on an agonist, especially if they're younger, if they're maybe relatively mild. But you've got to be vigilant about the agonist side effects as well. So,
right. Yeah, there are some unique side effects that have been discovered with dopamine agonists, and they were discovered because someone actually listened to their patients, and a lot of these I think had been maybe going on for a while before they got the proper attention.
Yeah.
But we have, you know, a lot of the medications that we have now are really designed to treat the maybe the complications of levodopa, try to make levodopa use better. So we have things like COMT inhibitors and MAOB inhibitors and things that all have effects on dopamine that if it wasn't for these complications and like fluctuations and dyskinesia, then levodopa would be the perfect drug. And that's
right.
what we've used.
So let's take a step back in terms of early Parkinson's, because as we've said, there's more and more focus now on the non-motor symptoms. And sometimes levodopa actually does have an impact on non-motor symptoms, but often they remain sort of in a class of their own in terms of treatment. So how do you go about do you take sort of just lists, or how do you figure out which non-motor symptoms are either potential issues or that you want to work on treating or prioritizing?
Well, again, it's asking the patient simply what bothers them the most, and there are some non-motor symptoms that I treat routinely. You know, sometimes I can look at a patient and I can tell, oh, this person is very depressed. You know, if they're crying in my office, and I think maybe the best thing to do would be to treat their depression. If they have trouble sleeping at night, it's very common in Parkinson's to have sleep disorders, either not sleeping enough or sleeping too much. And so we may need to adjust medications, even taking away medications that may make them more drowsy, or give them sleeping aids and sleep hygiene techniques and things that can help. And all of these things, I always tell people, all these things will make your Parkinson's better. If we make you sleep better, if we make your mood better, they're at least going to tolerate their Parkinson's better. And so we don't just focus on the motor symptoms. Even constipation, big problem in Parkinson's disease, and patients feel much better when they're a bit more regular.
Well, I agree 100%, and I think that one of the things that I try to make myself do is to always ask the second question, which is why? You know, because it can be Parkinson's, it can be not Parkinson's. So, for example, the patient says, "I'm not sleeping well." Sure, it could be Parkinson's. Even within Parkinson's, it could be a REM behavior disorder, which you might treat one kind of way. It might be that they wake up because their tremors or their rigidity is interfering. It might be that they wake up because they have frequent urination or urgency, which can happen in Parkinson's. It might happen because they're anxious or they're depressed. It might happen because they have a huge mortgage and it really doesn't have anything to do with anything I'm able to fix. Right. So, you know, trying to figure out, does the problem fall into this subcategory, and then working, if I feel comfortable with that particular non-motor symptom myself, or if I've tried and had problems working with another subspecialist, such as, you know, if I can't manage the constipation after 1, 2, 3, to have maybe a GI specialist weigh in. Am I missing something here, or a sleep specialist? But a lot of times we are able to manage these things on our own.
Yeah, we're good at handling the basics, but things as they get more complicated, I often get help from people who know more about some of the other symptoms. If somebody's very depressed and they don't get better with, I give them an SSRI, well, I'll get a psychiatrist to help out. And if same with constipation or sleep disorders, because we can't know everything about how to treat all these things. So I think it's good to have a good team approach with your other colleagues, as well as therapists. Speech therapy, voice therapy can be very very useful, as well as the medications. So I think it really is a disease that affects virtually the whole body at some point, and so we need to get a lot of people helping out, and we need a good team around these people, especially as the disease progresses, including things like home care and making sure they get their medications on time and get good meals and things like that. So I think it does get complicated. My goal is always to keep people living at home. Yeah. So I think you do the right things. It happens most of the time. What do you think about some of these other non-pharmacological treatments? I know we hear a lot of them here in New York, like dance therapy and boxing and things like that. Do you recommend that to your patients?
Yeah, I do, partly because some of the data is encouraging and positive, but I also think because part of our job is to motivate, and part of the lack of dopamine can sometimes be a degree of apathy. And so I think getting patients engaged in their environment, both mentally and physically, is part of sort of my responsibility at making sure that they're doing well, because you will hear Parkinson patients routinely say, when I'm doing something I love, I sometimes go an hour or two without my levodopa, and then all of a sudden I realize I forgot it. Whereas the patient that's not as active, I think, is much more likely to have a lot more burden from their Parkinson's.
Yeah, I agree. I think these people have a tendency to get very unmotivated, and their world gets smaller and smaller. And I think to give them other things to do, to get out and be amongst other people, if they like to dance, I've had people get very excited about going to their boxing class, and they say it helps their balance, and they look forward to going out and doing that for the exercise. And I think it's all part of our whole treatment options.
What do you consider to be the biggest challenges in let's say not advanced Parkinson's, which has a lot of challenges, but in sort of that early to middle range when patients are starting to experience maybe some fluctuations, some dyskinesias. They're still doing well generally, but they're coming in now with a few more complaints and issues.
Yeah, a lot of those have to do with wearing off of medication. So if their levodopa, which they're probably on by this time, doesn't last from one dose to the next, then they can be very well treated, and then within even a matter of minutes, be very stiff and slow and may have tremors and trouble walking, and that can really affect quality of life. Dyskinesia, interestingly, a lot of times dyskinesia is more bothersome to people around the patient and not so much to the patient themselves, because the patient feels the medication is working, but they're moving better, but maybe moving too much now, but that's better than not moving at all. So from what I hear from patients, being off your medication where it's not working is one of the worst feelings that they can have. So the goal in that middle range person is to keep them with more on time. So keep them as smooth as possible in their response. We have a lot more medications that we can use to try to accomplish that. Again, we have the once a day dopamine agonists that can smooth out some of the ups and downs. We have COMT inhibitors that will extend the half-life of levodopa so they don't have to take it as long. And now a new form of levodopa that comes in little beads that absorb at different rates that give a longer delivery of levodopa so that people get a more smooth response. If these problems get to be unmanageable, then that's really a good indication for surgery for Parkinson's disease. And there are studies now showing that even earlier surgery may be a better thing than a lot of complicated medical management. So I think we're leaning more towards doing deep brain stimulation earlier on patients who have, certainly if they have motor complications, and maybe just even at the very onset of motor complications, rather than going through a lot of different medications to try to keep them away from the surgeon. So surgery may have an increased importance as we go forward.
Well, I agree. I think there have been 3 pretty decent studies at this point that have given us a little more encouragement about at least having the conversation a little earlier. It's
Right.
not for everybody. It's not appropriate for every patient, and some patients don't want it. But I think it is incumbent upon the neurologist to start bringing it up when patients are having fluctuations and dyskinesias, even as something so they know that there's something out there. Look, we're going to try X, we're going to try Y, we're going to change your dose interval, we're going to add an MAOB inhibitor, whatever the case may be. And if you're still having a lot of off time or troublesome dyskinesias, then this is something that we now have that can improve quality of life. So I agree. I think that that's something that has got to be in the armamentarium and as part of the conversation when you have that middle Parkinson patient.
Mm-hmm. Right, and then as time goes on, we get through that stage, and then it's more in the 10, 12, 15-year disease range that people really have more problems that are more complicated and difficult to treat. So things like trouble with balance and falling, cognitive problems with delusions and hallucinations, which some of those can be made worse by medications. These are the things that really get to be challenging to treat, and that's where sometimes it's better to really simplify the treatment rather than make it more complicated.
I say often that I spend half of my life giving levodopa and half of it taking it away, because unfortunately as we do advance in the disease, that's where we do run up to some of the limitations of where we're at now. And dementia, cognitive impairment doesn't happen to everybody, but when it does happen and is prevalent, sometimes treating the Parkinson's almost becomes counterproductive. And we do have some things that can help with cognition and certainly with hallucinations, but a lot of times we've got to step back at that point. You don't want to be just building up someone's medicine because you think it's going to overcome their imbalance when it doesn't. So knowing what our treatments where they hit their limitations, such as freezing of gait and cognitive impairment, is an important aspect of knowing when you have to be honest and say, we don't at this point have a medicine or surgery for that, but we're going to work with physical therapy or visiting nurse service or whatever the case may be to help the patient and sometimes their significant other too.
And I think there's some drugs in development that maybe in the coming years we're going to have something that might do more to actually treat the underlying problem, the actual pathophysiology, rather than just treat the symptoms. So we might be able to have some effect on disease progression, maybe even, best case scenario, reversing some of the problems. And I think that's is pretty exciting when you think about how this really has been going on for 40, 50 years over the evolution of treatment of Parkinson's. Not a long time in medical history that we've got a lot of neat things on the horizon.
So, David, I share your enthusiasm and optimism for some of the things that are coming down the pipeline, but and patients are very excited about it too. But I try to also keep them excited about some of the really neat things that we do have now. Right. Medications. We mentioned deep brain stimulation, but there's other advanced options out there that really can make a big difference for brittle Parkinson patients. Things like the apomorphine injection, or now the levodopa infusion. And some of these are, not something maybe that every neurologist is going to be comfortable using, but knowing they're out there and can make a difference in patients where it's become very difficult to, divide the doses, can simplify regimens that seem otherwise very complicated. So between looking more closely at the non-motor symptoms and being able to really smooth out a lot of the motor symptoms now with all of the medications and interventions we have, I think we really can improve the quality of life of Parkinson's patients for many, many, many years.
Right. Yeah, I agree. I think there are a lot of options for patients these days, and I think that's when it's most important for a patient to be in a center where they understand movement disorders and Parkinson's disease, because then you have all the options available. If you're don't have access to a movement disorder center, well, then that's where you can go to support groups and find out what is available. But I think that there are many options for people that need to be explored and find out what is the best, again, for an individual patient. Patient may not be a candidate for brain surgery, but maybe a PEG tube would be an option.
So I think in conclusion, it's a complicated disorder. It's sort of a hydra-headed thing where you have a lot of different symptoms that you've got to bring together. But if you understand what the motor and non-motor symptoms are, it helps you make the diagnosis. Understanding what some of the medicines are, their side effect profiles, can usually help most patients for many years. And then when you do get to these more advanced options, know where patients can turn to get more information on them and see if which is appropriate. And the big thing is also just empowering the patient through support group, through research opportunities. I always encourage people to look at sites like clinicaltrials.gov to see if there are things in their area that might be relevant, and to again, try to keep things optimistic in terms of what we can get better and grapple with some of the limitations that we do have.